This is the Glytone range of products that are going to be used. Each of these products, Glytone 2, 3 and 4, are based on a triple association. Non- or low reticulated hyaluronic acid, which we know plays an important part in the stimulation of collagen production by fibroblasts. Reticulated hyaluronic acid, that is used as a dermal filler. And finally, the innovative association with mannitol, playing a major antioxidant role, acting not only on the mechanics of these injections, but also scientifically and physiologically on the effects of the products themselves. To optimize the injection of these products, fine or micro cannula of varying lengths and calibers will be used. The different cannula will match the needs of the individual product and the treatment area concerned. Glytone 2, the least reticulated of the range, will be used in areas where the skin is particularly thin or where the lymphatic system is sluggish, for example the periorbital area, and for fine lines around the mouth. Glytone 2 is primarily designed for areas beneath the eyes, the tear troughs, the periorbital zone. The most versatile of the range is Glytone 3. It is an excellent product that can be used extensively, being equally effective for fine lines as well as a filler. It really is a reference product that can be injected into the lips, the nasal grooves, the tear troughs and cheeks. It may be the flagship of the range, but close in the wings is Glytone 4. Number 4 is also a filler, but has the enormous advantage of being extremely fluid and can be used with very fine needles, something that is practically unique in the context of dermal fillers, which do tend to be quite dense. In this first section, the merits of using cannula with rounded ends will be examined. Cannulas facilitate a lateral extrusion of the product. They are very flexible and will adapt to subcutaneous contours, reducing any trauma to adjacent or underlying soft tissue. Even though the use of cannulas is practically painless, a local anesthetic cream such as Anglais can be applied 30 to 45 minutes prior to the injection. This will help to put the patient at his or her ease. It is important to relax the patient. Glytone and Pierre Fabre provide anti-stress reliever balls that have a valuable role in helping the patient to relax. Injections into the temple area using microcannula. First, a visual aid for the injection and the identification of strategic points within the temporal area. Before beginning, the area is carefully and thoroughly disinfected, especially due to the close proximity to the hairline. A small point of entry is made with a needle that allows the soft-ended cannula to be inserted and a triangular coverage of the area. The results are regular and even. As per the diagram, the treatment zone is actually drawn on the patient's skin. The temporal margin, the upper zygomatic area and the orbital cavity. The injection point that will enable an even coverage of the area is situated at about 1.5 cm above the zygomatic ridge. Disinfection is carried out carefully to avoid removing the written markers, and an initial opening is made with a needle for insertion of the cannula. A 27 caliber cannula is used and is inserted with ease, making a gentle, blunt subcutaneous dissection of the temporal zone. This gentle, blunt dissection with the cannula carefully avoids contact with the various small blood vessels, as well as nerve endings linked to the facial nerve that extend to the forehead and temporal areas. These are indeed much deeper in the facial temporalis superficialis than the chosen injection plane. Contralateral application of the finger will allow you to massage and spread the product for better coverage. You will observe that there is no vascular lesion and that the patient does not recoil in pain. The procedure is painless, and yet the cannula makes a gentle, blunt dissection of the fibrous septum, giving a higher quality result and more effective coverage of the temporal zone. For this patient, the treatment area chosen covers the upper and lateral temporalis to enable the temporal hollows, particularly marked in this case, to be filled. For the anterior portion of the zygomatic zone corresponding to the lateral cheekbone area, the anterior subcutaneous injection plane allows for coverage under the malar fat pad and continues to be subcutaneous within the orbital zone. This small adjustment to the injection plane is significant, as there is virtually no fatty tissue in the temporal orbital area, whereas the lateral cheekbone and anterior zygomatic zones have a richer source of adipose deposits. A deep subcutaneous injection into the fatty layer is required to achieve a lateral contouring of the cheekbone area. A post-injection massage helps to spread the product more evenly, and you will notice the absence of vascular lesions and bruising. The left side shows clearly where the hollow temple has been filled. It is nonetheless useful to apply a local vasoconstrictor, and icing still remains the best method. Glytone provides mini ice packs to place on the skin with a material coating so that there is no direct contact with and burning of the skin. The same procedure is carried out on the other side, using the same strategic points of reference, not forgetting the disinfection, especially as the hairline is so close. A compress can be used to push the hair back if necessary. The initial entry point is made, as you can see, in the anterior portion of the zygomatic zone, or the lateral cheekbone area, and the 27 caliber cannula is inserted to ensure the diffusion of the product into the zygomatic orbital zone. In the upper area, towards the eye socket and anterior temporal zone, this is more superficial as the injection plane is strictly limited due to the lack of adipose tissue in this area, in stark contrast to that of the lateral cheekbone or zygomatic area. In this part we will be looking at injections using a flexible cannula into the eyebrow region. Firstly, a look at the diagram to remind ourselves of the strategic points. A lateral entry point at the base of the eyebrow, disinfection of the treatment area, creation of an initial point of entry, and of course the insertion of the cannula giving an even distribution of the product within the axis of the eyebrow and below. Here we are using a deep subcutaneous injection plane corresponding to the Sharpier's fat pad. Once again, the treatment area is sketched on the patient's skin and the lateral entry point identified. A disinfection of the area is carried out using a colourless disinfectant, and then an initial aperture is made with a needle at the base of the eyebrow at an angle of about 45 degrees. The use of magnifying glasses will facilitate the insertion of the 27 caliber cannula. By contralaterally applying your finger and using fingertip palpation, the correct positioning of the cannula can immediately be verified. The product can be spread more evenly and any clogging of the filler avoided. Notice the absence of any pulling back by the patient who has only had a local anaesthetic cream applied to the area. There is no truncal anaesthesia in this case. See also the progressive entry of the product into the treatment zone and how this leads to a slight elevation of the eyebrow by filling the area below. Injections of the dermal filler into this area produce the sought-after, fuller, rejuvenated look and correct sunken eyes that classically give a tired and older look to the patient. From a lateral approach, you can see the filler going into the whole length of the eyebrow, from the top, through the middle to the base. Don't hesitate to inject below the top of the eyebrow to achieve an even spread and to avoid having the bulk of the product in the lateral part only. The same procedure is carried out on the other side, and the treatment zone is sketched on the skin. Once again, the initial classic entry point. The insertion of the 27 caliber cannula and Glytone 2. It should be emphasized here that this product is a low reticulated product and designed particularly for this treatment area, in that it avoids the bruising that is so often associated with the periorbital area. The contralateral application of your finger provides a level of security in terms of the eye and in verifying the even spread of the product. A fingertip massage is again useful to ensure an even result and should be carried out facing the patient to be certain of a harmonious and symmetrical finish. Injection of hyaluronic acid into the glabular area for frown lines. The strategic points are identified. In fact, there is a single midpoint between 1 and 2/3 up on the forehead that enables an even coverage of the entire treatment area. Firstly, disinfection, then the initial entry point made with a needle, and finally the insertion of a 27 caliber cannula for a triangular coverage of the area. A retrotracing technique is used for the injections from the mid-entry point. To ensure perfect symmetry, the practitioner needs to be looking down onto the patient's forehead. The entry point must be absolutely at midpoint. The cannula is inserted, and with a subcutaneous, gentle, blunt dissection, the different septum in the treatment zone can be separated. This retrotracing technique is systematically used for these injections to avoid any intravascular injection. Important zone in the mediofacial area, the tear troughs. The tear troughs. The injection treatment zone is defined. The upper anterior area correlates with the under eye area, and the exterior area correlates with the median cheekbone area. The central area corresponds to the actual tear trough, the groove in the malar fat pad that appears to bisect the cheek. Once the disinfection is done, the entry point is made, allowing an even distribution of the product, the whole length of the tear trough, going from under the eye to the median cheekbone. My finger indicates the line of the actual tear trough along the inner cheek, above the nasal groove, running in the same axis as the facial artery. This time, a 25 caliber cannula is chosen to treat the whole area. By positioning and guiding with the finger contralaterally at the under eye level, and using a subcutaneous injection plane into the deep fatty tissue of the tear trough area, the product is progressively injected using a retromuscular technique behind the eye orbicular muscle, moving upwards towards the under eye area. An adjustment is made between the subcutaneous injection plane associated with the adipose tissue of the malar fat pad and the retromuscular plane beneath the finger. This adjustment happens quite naturally without any particular effort on the part of the practitioner, and you can see here how we have the recontoured cheek area from the fatty pad going up to the edge of the eye cavity. And you can see here how we have the recontoured cheek area from the fatty pad going up to the edge of the eye cavity. Injections into the nasal groove. The injection treatment area is sketched on the patient. This area comprises the nasal groove but also extends above and below due to the presence of deep adhesions between the skin and the levator muscles of the corners of the mouth. These impenetrable adhesions within the overlying adipose tissue are what accentuate the groove with age. The use of the cannula is particularly interesting here, as the gentle, blunt dissection prior to coverage of the zone produces an even result along the whole length of the nasal groove, perhaps unlike with a needle. There is a standard point of entry. The insertion of the cannula before injecting the product enables a gentle, blunt dissection of the fibrous septum with some resistance, as you can see. This resistance can cause the patient to feel a cracking sensation that may sound unpleasant but is painless. Once the gentle, blunt dissection is complete, the product is injected using a retrotracing technique all along, above and below the nasal groove for total coverage of the treatment area. For facial symmetry, avoid over-contouring this area. Injections into the marionette lines. The diagram shows the injection zone. The same entry point as for the nasal groove will be used, and a systematic disinfection of the area carried out. This point of entry means the injection can be made from top to bottom, and the passage of the cannula in this direction causes a slight shrinkage or retraction of the fibres that in turn create a sort of sling to support the labial commissure. There is a dual effect, the injection and the resulting shrinkage of fibres. The gentle blunt dissection will affect the end result due to the shrinkage of the fibres, creating a sling to support the corner of the mouth. The insertion of the cannula enables the product to be injected into the triangle below the corner of the mouth. Glytone 3 is perfectly adapted for treating this area. The same procedure is carried out on the other side in a symmetrical fashion. Fingertip massaging will enhance the evenness of the result. You can see the difference in elevation from one side to the other. Even though the same entry point as for the nasal groove is used, it is useful to reopen a channel with a needle for insertion of the cannula. Again, the gentle blunt dissection from top to bottom, the creation of a fibrous sling in what would be described as a vector-like way, as the triangular motion facilitates the injection of the product and the subsequent shrinkage of fibres to form the sling. Injections into the lip area. This section will cover the different techniques used for enhancing or augmenting the lips, and for treating those wrinkles known as bar code or smoker's lines. In other words, the vertical lines above the upper lip line. For lip augmentation and hydration, an entry point on either side of the mouth will be used for the upper lip and a single point for the lower lip. When treating the philtrum ridges or columns, only a needle can be used, with 2 entry points on the lower part of the ridge. This will enable the philtrum to be recontoured as well as the Cupid's bow. The 27 gauge cannula is inserted into the red part of the lip, where the moist part joins the dry, on the vermilion border. The right half of the lip can be treated from this point. This area can be used as a pressure point over the teeth, and filling this line between the moist and dry lip using a cephalic rotation of the lip creates a hem and adds volume, whilst avoiding any overcorrection. Using a cannula in this traditionally sensitive area makes for a less painful injection and, most importantly, an absence of trauma. For the upper lip, 2 injections are necessary. Firstly, the initial entry point made by needle and then the insertion of a 20 save Firstly, the initial entry point made by needle, and then the insertion of a 27 gauge cannula. Starting with filling the moist dry lip line to achieve symmetry, using the same cephalic upward rotation of the lip, the injections are made in a retrotracing manner. You can see the absence of bruising despite this area having been explored twice. The two channels made by the cannula join at the philtrum. There is no recoil by the patient and the immediate result is even and symmetrical. Here, a fingertip massage is vital and avoids any local accumulation of the product. A gentle massage with moistened fingers is advisable, as the lip area is sensitive and fragile. Only a needle can be used for the treatment of the philtrum columns. The philtrum can be recontoured or redefined by going into the base of the philtrum ridges on either side. Symmetry is essential, and so injections are made from top to bottom. You will notice the slightly hemorrhagic nature of the needle injections as opposed to those made by the cannula. Post-injection photographs are very valuable. The patient will return in 15 days after the reduction of any swelling. Cannula injections versus needle injections. Traditionally, using a needle facilitates and offers a familiarity in its handling rather than the newness of the cannula, but we do believe that there are inconveniences too. Firstly, pain, and with that the phobia that we see in a lot of our patients. Also, there is the hemorrhagic aspect, and finally the reduced uniformity of the injection. This patient will be treated in different areas with both the needle and the cannula, using the same products with varying degrees of reticulation and on different injection planes. For the tear trough on the right hand side and up to the under eye area, we will begin by using a needle. The product is extruded at the very extremity of the needle. Traditionally, injections into the area under the eye are retromuscular and extraperiosteum. The contralateral finger controls the depth of the injection and the quantity injected into the bag area. Now we continue down the tear trough with the needle, administered in a fan-like movement to correct the anterior cheekbone area. By being patient and careful when using a needle, complications can be avoided. These injections can be made the whole length of the orbital arch to redefine the contour of the malar and zygomatic zone from under the eye to the lateral cheekbone. On the left-hand side, a needle is used for superficial filling of fine cheek lines. These fine wrinkles can be treated by thickening the dermis using a mesh technique. The minute serial puncture marks of the needle are visible and small bruises appear. We can see a slight bruising appearing in the upper area. These minor post-injection sequelae are classic when using a needle. The quality of the end result is not, however, affected. Applying light pressure to both sides of the treatment area will reveal if sufficient thickening of the dermis has been made. Looking at the other side now, for the same treatment we will use a cannula. After an initial entry point has been made, the 27 gauge cannula is inserted. Magnifying glasses will assist in locating the entry point and in continuing with the breakdown of the subcutaneous fibrous septum, adopting an approach perpendicular to the axis of the wrinkles. Once again, the patient will hear a cracking sound that may be unpleasant, but is totally painless. Once the gentle blunt dissection is made, the product is injected into the already demarked treatment zone using a retrotracing technique. The objective is the same as with the needle, to thicken the interface between the subcutaneous tissue and the underlying facial muscle plane. This fan-shaped technique not only releases adhesions, but also ensures an even coating by the product. At the glabella, we can make a similar comparison. An initial entry point for the frown line on the right side. The insertion at an angle of 45 degrees of the 27 gauge cannula. The insertion at an angle of 45 degrees of the 27 gauge cannula. A gentle blunt dissection within the channels under the skin before using retrotracing to inject the Glytone dermal filler into the globular zone. You can see that there is no painful recoil on the part of the patient and no discoloration or bruising. Using a needle for the frown line on the left side, the product is injected in the traditional way, and you will notice that the compress is becoming increasingly red as we make different needle punctures in the area. Using a needle will cause slight bleeding, but will not affect the quality of the overall result. It should be added, however, that the patient is more aware of the needle, and injecting the product in this way is more painful than with the cannula. We will look now at the two different techniques in the area of the mouth. We know that for the philtrum columns, a quality result and symmetrical recontouring is only obtainable using a needle, so no comparison can be made here. However, turning to the area above the lip, and in particular to the treatment of smoker's lines, the two techniques can be compared. Treatment of the philtrum will inevitably involve reconstructing the vermilion border at the Cupid's bow. Here you can see from the profile the recontouring of the philtrum dip and the enhancement of the vermilion border. The treatment of smoker's lines and the edge of the lip is done by needle, injecting in a retrograde manner along the length of the border between the moist and dry upper lip. To create a subtler and non-bulky look, a parallel injection is made above, using a smaller quantity of product. Observe the hemorrhagic nature of the needle punctures. Marionette lines are treated in the same way, by recreating volume and elevating the area beneath the corner of the mouth, using, in this case, a needle. The injections on this left side are made along the moist dry lip border, in a retrotracing flow, using an initial amount of product that is then followed by a parallel injection above of a slightly reduced amount, producing a subtler result. You can compare this patient with the previous one, where the area was treated using a cannula. Notice the overall look, the number of puncture points made with a needle, and the slightly increased hemorrhagic nature of this technique. Traditional use of a needle to fill this area can produce a uniform finish, but without the tightening and vector aspects of using a cannula. The nasal groove can be treated by using a fan technique for the injections, crisscrossing, using a mesh approach to ensure a better breakdown of deep-seated adhesions within the nasal groove area. This breakdown of adhesions is, it must be said, less effective than with the cannula, but for those practitioners who lack the experience of using a cannula, very good results can still be obtained. In all honesty, both techniques have their own merits. An initial single point of entry, the insertion of the cannula for a gentle, blunt dissection and the breakdown of the septum, then retrotracing injections to diffuse the product. It is clear that the absence of blood and the lack of pain make this technique our preferred choice. We can compare the glabella. The left side was treated using a needle, the right using a cannula. There is more bruising on the left side, but this will not affect the end result. On the cheeks, bruising is more obvious and the skin slightly more coloured on the needle side. The nasal groove is more or less symmetrical. We can see the various puncture points, but there is no bruising or discoloration. The entire lip area was treated using a needle on this patient to be able to compare with the previous patient on whom the cannula was used in the same area.